Welcome everyone to the new series of webinars being organised by the European Pulmonary Fibrosis Federation, EU IPFF, in the run-up to our second European Pulmonary Fibrosis Patient Summit, which we're going to hold from the 3rd to the 5th of November, and it will be a virtual event. Leading up to that, there are going to be 6 webinars, and this is the first of them. My name is Steve Jones. I'm the president of the European Pulmonary Fibrosis Federation. I'm also the chair of Action for Pulmonary Fibrosis in the UK. And I lived with IPF for 8 years before, very fortunately, receiving a lung transplant 6 years ago. It's my real pleasure tonight to welcome a friend of mine and a fellow trustee at Action for Pulmonary Fibrosis, Dr. Simon Hart, to talk to us on how did I get pulmonary fibrosis. Simon's a respiratory physician in East Yorkshire in the UK, and a reader in medicine at the Hull York Medical School. He researches a number of different types of respiratory disease, including pulmonary fibrosis and interstitial lung disease. He's also one of the clearest lecturers I've ever had when I try and understand myself what pulmonary fibrosis is all about. Simon will talk probably for about 30 to 35 minutes, and that should give us at least 20, maybe even 25 minutes for Q&A. Now, the system is slightly different on the Zoom webinar. If you look, there's at the bottom of the buttons along the bottom of your screen, assuming you're looking at a Microsoft screen, you'll see there's a Q&A function. Please do not use the chat function. The chat function is just for the speakers and back technical staff to talk to each other. If you have a question, please put it in the Q&A section, press the Q&A icon at the bottom, and please don't give a stream of consciousness. Best if you could make a succinct and clear question, which then it will be easy for Simon to respond to. Although you're all off camera, we are going to be recording the webinar tonight as well for our own purposes, but that webinar will then be available on our website if you would like to view it again. So, and without further ado, let me hand over to Simon, who's going to talk to us, Simon, about, new slide, how did I get pulmonary fibrosis? Over to you, Simon.
Thank you very much indeed, Steve. And hello, everyone. I'm talking to you today from Yorkshire in the north of England here, and a warm welcome to you all wherever you are tuning in from. This is my declaration of interests. So for today's webinar, I'll start off with a typical clinical case of pulmonary fibrosis. It's a fictitious case, but very typical of the sort of patient who would come to see me in my pulmonary fibrosis clinic. A 75-year-old man has been short of breath when walking for about 1 year. Initially, he puts it down to being unfit, maybe overweight, but realizes after a while that it's not getting better and it's actually getting worse, and so wants to get it sorted out. Very typical presentation. His past medical history is of high blood pressure on some medication, but he has no other medical conditions. He doesn't have a family history of lung disease. This may be important. We'll come back to why that is shortly. He had been a tobacco smoker, but had given up about 20 years ago, so in the distant past. He had worked as a labourer, so the sort of job where he may have been exposed to inhaled dusts of various different types, often poorly defined, wood dust, metal dust maybe. He does not keep any pets, and we'll come back to why that's relevant later. The physical exam by his primary care doctor, his general practitioner, revealed crackles when listening to the lungs with a stethoscope. This is very typical. We'll come back to this also. So his GP arranges a chest X-ray and refers him to the hospital clinic. This is his chest X-ray. This is abnormal. There is abnormal white opacification in both lungs, such that the edges of the heart and the diaphragms at the bottom are not as clear as they should be. A chest X-ray is often abnormal in pulmonary fibrosis, but in mild disease or very early disease, It may not be. It may be normal. So it's not fully sensitive for picking up a diagnosis of pulmonary fibrosis. At the hospital, we arranged the diagnostic test, which is to do a CT scan of the high resolution type. A high resolution CT scan is performed on a standard CT scan machine, but the program is instructed to acquire the images in a certain way and to reformulate them in the computer to give nice sharp edges, which give a nice definition of the insides of the lungs. And this CT scan on the right here is very typical of someone with pulmonary fibrosis, where there's a lot of excess lacy white appearances around the outside of the lungs, as opposed to the normal gray appearances, which is what the lungs should look like. Most often, a CT scan will reveal a diagnosis of pulmonary fibrosis. Sometimes the CT scan is unsure, indeterminate, in which case the patient may go on to have a lung biopsy, a surgical procedure performed under anesthetic to take a piece of lung that can be looked at under the microscope. In that case, a lung biopsy will often look rather like this. And biopsies are stained with pink and blue stains, hematoxylin and eosin. And this piece of lung shows very typical appearance of pulmonary fibrosis. The top left area up here is pretty normal. You've got these nice thin walls of the alveolar gas spaces, which are thin and perfectly formed for transferring gases between the air and the blood, which is in here, through a nice short path, a thin space. Some of these other areas on the right are grossly abnormal with lots of excessive pink staining. And collagen, scar protein, fibrosis, stains pink. And there are certain other areas which probably represent newly forming fibrosis, like this little pale blue area here, which is called a fibroblastic focus. So what we've got here is a patchy appearance with some areas of normal lung, other areas of fibrosis, and fibrosis that is scarring of various ages, some which is recent, some which is older. And that's a very typical pattern of what we see in pulmonary fibrosis. So I'm showing you this information just to give us a background feel of what we might find on the standard tests that we might do in a patient who comes along with suspected pulmonary fibrosis. And we'll be able to relate back to some of these features a little later on in the talk when we start discussing why pulmonary fibrosis happens and how it happens. So with that context, let's just have a general think about what pulmonary fibrosis is. And a bit of historical context is often helpful in this situation. There are some diseases that seem to have been around for millennia. Very old diseases can be found in Egyptian mummies, etc. Pulmonary fibrosis doesn't seem to be like that. It seems to be a more recent disease in medical history. This is one of the earliest descriptions by Dominic Corrigan, the Irish physician, in 1838, when he described cirrhosis of the lung. Cirrhosis is a condition used to describe a very scarred liver, perhaps due to viral infection or due to alcohol. And cirrhosis, the word, arises from the Greek, reflecting the yellowish appearance of the very scarred liver. And Corrigan described scarring of the lung, which he called cirrhosis of the lung. We don't call it that anymore, but it's an interesting initial historical description. Then to get more information, we have to jump forward over 100 years, really to the 1960s, where a lot of the work describing what pulmonary fibrosis is was done by this gentleman, Avril Liebau, an American pathologist, who looked at lung specimens from patients with pulmonary fibrosis and described them as being shrunken, scarred, often with a honeycomb appearance, that is, a number of small cystic areas, which you might be able to pick out in the gross lung specimen on the right-hand side of this slide. And some of the terminology that Liebau used in the 1960s to describe pulmonary fibrosis is still in use today, for better or worse. What about the clinical features then? Well, we've already got a feel from that from the case that I presented. The a symptom is what a patient complains of or reports. A sign is something that your doctor or healthcare professional finds on doing a physical examination. So the symptoms, very typically, as described in the case, of progressive shortness of breath on exertion, typically in a person who is over the age of 50. Not always, but most of the time. And often a dry cough. That is a cough that is not productive of sputum or phlegm, but it may be sometimes. Sometimes there is phlegm. So breathlessness and cough are the cardinal symptoms of pulmonary fibrosis. But of course, there are also symptoms of many other respiratory diseases, diseases of the lungs. So it's not unusual for a patient with new pulmonary fibrosis like this to perhaps get diagnosed wrongly with something else first, like COPD, chronic obstructive pulmonary disease, or asthma, because these are more common diseases that people are more familiar with, healthcare professionals are more familiar with, and for which there is good treatment often. So sometimes a diagnosis of one of these other conditions is given for a while until it becomes apparent that it's not behaving as we would expect in that situation and not responding to the treatment. We mentioned earlier these crackles, which are heard on listening to the lungs with a stethoscope. Auscultation is the medical word referring to listening with a stethoscope. Normally, when you listen to lungs with a stethoscope, you just hear the sound of the air going in and out, nice soft sounds. So crackly sounds, like you would hear on an old vinyl record if it was scratched, are not normal and are very typical of pulmonary fibrosis, although again, there are some other conditions that can cause crackles as well. So a little bit of thought needs to be applied. And you may find, if you see your GP or your respiratory physician or your pulmonologist, that they'd be very interested in examining your hands and your fingers. And that is because there may be changes in the fingers, particularly an increase in tissue in the nail bed here behind the nail that leads to this very curved appearance called finger clubbing, which sometimes occurs in pulmonary fibrosis for reasons that remain unclear, it would be fair to say. So that's a bit of background about the nature of pulmonary fibrosis, how it might appear in terms of symptoms, what your doctor might find on examination, and a bit of the historical background. People often ask, well, what's the cause of my pulmonary fibrosis? And whilst some things are often referred to as causes of pulmonary fibrosis, I think it is better and helps to refer to, not to causes, but to risk factors. There are a number of characteristics that will increase a person's risk of developing pulmonary fibrosis. And we'll just go through some of these now. So risk factors rather than causes is a better way of thinking about things. And in terms of many diseases, or maybe most diseases or all diseases, risk factors comprise a combination of genes and environment, what you're born with, and then what you're exposed to over your lifetime. And pulmonary fibrosis is exactly the same, genes and environment. So there is no doubt that your genes, your genetics, does influence your pulmonary fibrosis risk. If you have an affected relative, and particularly a first-degree relative, so that's a parent or a brother or a sister with pulmonary fibrosis, that increases your risk. There is no single gene that causes pulmonary fibrosis or confers risk of pulmonary fibrosis. So it's a bit like heart disease, coronary heart disease, or high blood pressure or diabetes, where there are actually many different genes that contribute. But if you have a family history of any of those conditions, you are more likely to get that condition yourself. And the same applies to pulmonary fibrosis. Sometimes it's difficult to tease out a family history because an older parent may have passed away some time ago from some type of lung disease, and it isn't clear what exactly they have. So it's not always clear from a family history, but we think that about 1 in 10 people with pulmonary fibrosis will have an affected first-degree relative. So genes are important, but not a single gene. There is no genetic tests that can be done, a bit like heart disease or blood pressure or diabetes, but it is important. And research then into the genes that do confer pulmonary fibrosis risk is important because it should throw light on what's going on with the cells and the molecules that's driving pulmonary fibrosis. In a similar way that genes that confer high cholesterol influence risk of heart disease, therefore linking cholesterol to heart disease. We hope and we expect that research into the genetics of pulmonary fibrosis will lead to similar links, hopefully leading to things that can then be targeted for future treatment for benefit of patients. So that's genes. What about environment then? So every day we breathe in and out many, many liters of air, and noxious or potentially noxious substances in the air we breathe is a big environmental risk factor for pulmonary fibrosis. And that includes tobacco smoke, often in the more distant past, as in the case we discussed at the very beginning of the man who stopped smoking 20 years previously. So it seems that even insulting the lungs in the more distant past can somehow lead to changes that confer a risk of later in life developing pulmonary fibrosis. Other dusts are less well defined, but may also be important. So people who work in their job with a lot of wood dust or metal dust, especially if they don't use proper respiratory protection, seem to be at increased risk as well. It's a little bit more defined what the nature of the dust is, a little bit more poorly defined, I mean, what the nature of the dusts are. But dust exposure does seem to appear in many people. Asbestos, shown here on the top right, is a naturally occurring fibrous mineral, and we all have asbestos fibers in our lungs. But in people who've worked with asbestos, that is definitely a risk factor as well. So we're always interested about what people's job was, and in particular, what they actually did when they were working. Other things in the environment that you can breathe in, less commonly in terms of pulmonary fibrosis, but are also important. And this comes back to the question that we asked our patient at the beginning about pets. Sometimes bird dander or mold, fungi, yeasts, when breathed in, can induce an immune response in the lung, which sometimes doesn't resolve and sometimes leads to fibrosis. So in people who keep pigeons, we would call that pigeon breeder's lung, sometimes budgerigars, caged birds, parrots, and sometimes other things like mold. So most of the time, if a pigeon breeder gets pigeon breeder's lung, on removal from the pigeons, it gets better. But sometimes it will progress to fibrosis, and that may be because the person has got other things that predispose them. So we'll come back to talk about combinations of risk factors shortly. Other things that can end up in the lungs may come from within rather than without. So anatomically, we are designed with our windpipe, our trachea, next to our food pipe, our esophagus, and linked at the back of the throat, which allows substances which normally should be in the stomach or the esophagus, the food pipe, to sometimes come up and actually be breathed in into the lung. And they often come up silently without any symptoms or any acidity or any heartburn. And the link between abnormalities of the gullet and the stomach and a predisposition to what's called reflux and pulmonary fibrosis has been shown many times. Whether it is truly cause and effect or just a link without causation, we're not entirely clear about, but it seems very clear. And it certainly fits with the idea that inhaling something that should be in the stomach, which might be acid or might not be acid, but might contain digestive enzymes, etc., or salts, into the lung, could be an insult that subsequently leads to pulmonary fibrosis through mechanisms which we will cover shortly. Some people have other medical conditions which definitely confer a risk of pulmonary fibrosis. So a classic example would be rheumatoid arthritis, shown here. This is an autoimmune disease that affects the joints, but also many other parts of the body, including the lungs. Another example would be scleroderma, which is another autoimmune condition that predominantly affects the skin, causing thickening of the skin, but also affects the lungs as well, in the form of pulmonary fibrosis. Exactly why and how people with these conditions develop pulmonary fibrosis is not clear, but there is a definite link there that should give us a clue, or should give researchers a clue about how autoimmunity can influence pulmonary fibrosis. Whilst these conditions tend to be treated with drugs that suppress the immune system, and that works very well for the joints in rheumatoid or the skin in scleroderma, the lung disease sometimes doesn't respond so well to this sort of treatment. So we want to know whether the patient has one of these conditions, and sometimes it may be difficult to tell, especially with something like scleroderma or some of the other rheumatic diseases. And again, a close scrutiny of the patient's symptoms and a physical exam may reveal it. Medically, these tend to be called the connective tissue diseases, which is not a very helpful term. Perhaps the term rheumatic diseases is a better one to describe this collection of diseases. Some drug therapies, medications, are associated with pulmonary fibrosis risk. Luckily, there are very few of them. The classic example is a drug called bleomycin, which is an anti-cancer drug. Obviously, fortunately, most people never receive bleomycin, but it's been well recognized for a long time that bleomycin, especially when used in high dose, can cause lung fibrosis. And indeed, in laboratory experiments, researching into animal models of pulmonary fibrosis, it's still used as an inducer of pulmonary fibrosis. So that's bleomycin. There are very few other medications, but the commonest one that I see nowadays in my outpatient clinic is an antibiotic called nitrofurantoin, which is used for the treatment of urinary infections, which is fine when it's used as a short course, but some patients end up on it for months or even years, long-term treatment. And some of those patients can develop pulmonary fibrosis. So if you take long-term nitrofurantoin and you were to develop cough or breathlessness, you should suspect the drug and speak to your doctor. So we can put all of those together, along with the one risk factor that I've hinted at, but haven't actually mentioned specifically so far, and that is older age. So pulmonary fibrosis is often a disease that gets more common as people get older. So we've got an age-related disease with a genetic predisposition, perhaps a family history, and various environmental or autoimmune insults that may contribute to pulmonary fibrosis risk. And for many patients, it's probably a combination of these factors. The age, perhaps the family history, perhaps the smoking in the past, may combine to confer that risk. If you're a patient with pulmonary fibrosis and you have none of these risk factors, then that just exemplifies that we don't fully understand all of them. But some of these risk factors may be kind of silent, like the reflux and aspiration on the bottom left here. So that may still be happening even if you don't have any symptoms. So with those risk factors in mind, these are useful for the healthcare professional when assessing a patient coming along with new symptoms, because the presence of one or more of risk factors for pulmonary fibrosis clearly make pulmonary fibrosis more likely as a potential diagnosis, as opposed to some of the other conditions which may appear in a similar fashion. So these are important things to recognize, but also from a research perspective, because if we understand what the risk factors are, we can therefore hopefully try and work out why those things confer risk, and then that may lead to the discovery of something that can be targeted by a new drug therapy in the future, for example. So with these things in mind, and we'll come back to these risk factors, let's have a think about what actually is happening in the lung in people who have pulmonary fibrosis. So here we have to think about a bit of the normal lung anatomy, which is composed of airways that take the air down into the business part of the lung, the trachea, and the main airways that divide about 15 times till you get right to the bottom. And if we blow up the bit at the bottom, we've got these tiny little air sacs that we saw a little bit of on that biopsy cut through in cross section. And these little air sacs are where the business of the lung is done, which is the exchange of gases between the air and the blood, which is what the lungs do. And each of these air sacs, width of a couple of human hairs, there are about 70 million in the human lung altogether, and that gives an enormous surface area for gas exchange. So let's take one of these little air sacs and then flatten it out, basically, to make it simple to look at. And these are the alveoli, and the air comes in down the airway tubes into the air sac here. It's lined with these green cells, which I've colored green, which are the lining cells, the so-called epithelium. The blood in the capillaries passes nearby. And in the middle there is the interstitium. And that's the bit in between the air sac and the blood. And normally it's very, very thin. I've just expanded it here for diagrammatic purposes. And we'll look at a little bit more detail at that. But you will hear diseases like pulmonary fibrosis referred to as interstitial lung diseases. And that's because this is where the disease happens, in the lung interstitium between the air sac and the blood capillary. Let's zoom in and have a closer look. So here we are. So what's normally in this interstitium? Well, normally in this interstitium, there are some cells called fibroblasts, and fibroblasts secrete proteins, often structural proteins that make the structure of a tissue. And one of the proteins they normally produce in the lung is elastin. And as its name suggests, elastin is very elastic, and it gives the lung a lot of its stretchiness and elastic recoil. The lung's normally a bit like a balloon. It inflates with air, but then it will deflate by itself. It has elastic recoil because of the elastin tissue. So that's what these cells normally do. So let's just remove some of these features and then think about what's actually going wrong or what happens in pulmonary fibrosis. In pulmonary fibrosis, it appears that these fibroblasts proliferate. They divide 1 into 2, 2 into 4, 4 into 8. So there are more of them. And they continue to secrete structural proteins, but instead of secreting elastin, they secrete collagen, which is the scar protein. It's the protein that your body produces when it's healing a wound. This is like wound healing gone wrong. There doesn't appear to be any obvious wound, but the fibroblasts are reacting, proliferating, and producing scar protein collagen, which, unlike elastin, is not stretchy, it's stiff. It's like cement. So this interstitium seems to be filling up with cement. And then the interstitium expands because of all this activity. Some of these fibroblasts turn into muscle-like cells. They continue to produce cement-like scar protein called collagen. And so we end up with a situation, something like this on the right, where we have a thickened interstitium full of cells and collagen, which is no good for the function of the lungs because the lungs lose their stretch and because there's now a much bigger path between the air and the blood for the gases to traverse. So that's what we know, like from looking at that biopsy earlier, that's what we know happens in pulmonary fibrosis. But one of the challenges is, well, why does that happen? What starts it off and causes it to continue? And that is a challenge because we can look at a biopsy and we can look at a CT scan, but that just gives a snapshot in time, just a look at that disease at that one point in time. And if you repeat the scan, you can see changes, but again, you're just getting little snapshots in time and you're trying to work out what goes on in between in real time. And that is difficult, and that has proved difficult from a research perspective. So what I'm going to show you now is one explanation for why this happens. It's not the only explanation, but it's one for which there is a reasonable amount of scientific evidence. So I'm not suggesting it's the whole story, but it is a story about why this happens in pulmonary fibrosis. So let's go back to our simple model with the lining epithelial cells of the air sac in green, the blood vessel lining cells in red, the fibroblast in the interstitium in brown. We'll add in a few other cells that are around, so immune cells in the airspace like macrophages, and then the immune cells and other cells that are circulating in the blood, because all of these cells are in and around the interstitium and may all be players in what goes on there. So it seems that any of these cells could send signals to the fibroblast that could lead them to proliferate and produce the scar protein collagen. And there may even be then cross-talk, backwards and forwards communication between these cells that may make things worse. Let's have a focus on the epithelial cells, these green cells here, these lining cells. The function of these is to line the lungs and to protect the lungs from all the injurious air and dust that we breathe in. And they have to continually replicate and replenish themselves in response to loss. And they have to do that throughout your whole lifetime. And what can happen, this is the replenishment, what can happen as we get older is that these cells get exhausted. They can no longer replenish themselves. They can no longer divide properly. And so they become senescent. Senescence is just a word that means old. They become old, perhaps they become old before their time. This is like premature aging. They've become exhausted. They can no longer carry out their functions. They don't die and disappear immediately, but they become bigger, as illustrated here, and they hang around. And one of the things that they do as a response to this inability, this exhaustion, is they send out chemical signals. And some of these chemical signals may then act on the neighboring fibroblasts to stimulate them to proliferate and produce the scar protein collagen. And it may not just be the epithelial cell here that becomes senescent. It may also affect the fibroblasts or the lining cells of the blood vessels here as well. So this is just one example. But it's important because it means that if we can target this process of senescence, we're trying to remove these senescent cells or target with therapies some of these chemical signals that are being sent out and driving the fibroblasts to produce fibrosis, then that may lead us in future to have better targets for drug therapy for pulmonary fibrosis. So understanding the biology, we hope and anticipate, will lead to better drug treatments and other treatments in the future. Just to illustrate that this process of senescence is a real thing, this is some work that my PhD student did with some lung epithelial lining cells in the laboratory, normal ones on the left, and the senescent ones on the right, which are bigger and also stained with a blue stain for senescence. So illustrating this is a real phenomenon that we can model in the laboratory to help understand the biology of this condition. So fibrosis occurs. Why doesn't it get better though? Because if we have a wound that heals with a scar because we've cut ourselves, eventually that scar will often resolve completely. It may completely disappear or end up much smaller than it was at the start. But the problem in pulmonary fibrosis is that it often does not resolve. In fact, it gets worse. In other words, once it starts, it seems to continue and likes to get worse and worse. And other mechanisms may come into play here when we're thinking about why does fibrosis not resolve? No, scar tissue can resolve because there are digestive enzymes that the body produces that can chop up that collagen scar cement, but that doesn't seem to happen. That resolution of wound healing doesn't seem to happen in pulmonary fibrosis. And there may be various reasons for that. Continued signals from the lining cells causing the fibrosis. The presence of these enlarged fibroblasts themselves may actually lead to a kind of positive feedback, self-perpetuating loop. Once it starts, it just drives more. And so there are lots of other potential ways that we need to try to understand pulmonary fibrosis in the future to get a grip of the biology. But what I want to emphasize from that last slide is that the nature of pulmonary fibrosis in terms of its tendency to progress or get worse is the key thing here. Many of the types of pulmonary fibrosis that you or someone you know have been diagnosed with are by their nature progressive. And here are some of them related to some of those risk factors that we talked about earlier: the rheumatic disease, asbestosis, hypersensitivity pneumonitis like the bird breeder's lung. The commonest that we see is idiopathic pulmonary fibrosis, but there are other diseases which have got funny abbreviated names which behave in a very similar fashion. And this is in fact a simplified classification. In a medical textbook, there would be many more different types of diseases listed here. But perhaps actually what matters more than what it's called is how it behaves. And if it's progressive, that is, has a tendency to get worse, then we can probably lump all these different conditions together rather than split them up into different ones. And the reason for that is that one of the antifibrotic drugs which we have used in the past for many years to try to slow the progression of idiopathic pulmonary fibrosis, the commonest an example disease here, that drug can now be used for a wide range of these conditions. Here's the approval last year from the European Medicines Agency that shows that nintedanib, also called OFEV, can also be used for what they call other chronic fibrosing interstitial lung diseases, which are progressive. In other words, progressive pulmonary fibrosis. Now, so if you have progressive pulmonary fibrosis, you may be eligible for treatment with nintedanib to try to slow it down, depending on the regulatory approvals in your own country, because sometimes these drugs are restricted to people with certain degrees of pulmonary fibrosis, which I shall just mention in a minute. So that's a bit about the biology of progressive pulmonary fibrosis and some of the areas that are being actively researched at the moment with the hope of a therapeutic benefit in the future. My last handful of slides is a little bit about the consequences of pulmonary fibrosis, what we've seen there, both in terms of reduced lung function, because that's what we measure, and many of you listening will have had lung function tests, so we'll touch on that, and then a little bit about how that pulmonary fibrosis leads to the cardinal symptom, which is breathlessness or shortness of breath. So in terms of the consequences of pulmonary fibrosis, one of the things that happens is that the lungs, because they get stiffer, they get smaller. Their capacity, the amount of air that can be breathed in and out, is reduced because of the loss of that elasticity that we talked about before and the stiffness caused by the collagen scar protein being laid down. So the lungs do indeed get smaller as the pulmonary fibrosis progresses. Here are two chest x-rays from a patient 6 years apart. And one of the things that may be apparent to you on the right-hand x-ray, as well as the fact there's more white fluffy opacification in the lungs consistent with pulmonary fibrosis getting worse, is that the lungs are smaller from top to bottom on the right-hand picture than they are on the left-hand picture. So that reflects the stiffness of the pulmonary fibrosis. And whilst we can see that on a chest x-ray, we can actually measure it more accurately with lung function tests or breathing tests. And in particular, the measurement that we focus on most is called the forced vital capacity. And if you've done lung function tests, you'll remember that you will do some measurements where you're asked to take a full breath in as much as you can, and then to do a long blowout until your lungs are completely empty, from full inspiration to full expiration. And that's the forced vital capacity. And that is the measure of lung capacity or lung volume that we use for a number of situations in pulmonary fibrosis, to assess the severity of it at the beginning, to monitor how it's changing over time. In some countries, for suitability for the drug therapies like nintedanib or pirfenidone, and as the key measurement to test the effectiveness of new treatments in clinical trials, which look to slow the decline in FVC that occurs over time. One of the consequences of these stiffer lungs is that when you breathe in, the lungs don't expand as much. So the brain is telling the lungs to breathe in, but the lungs are not moving quite as much as might be expected if they were normal and had perfect elasticity. That's important in terms of the the perception of shortness of breath or breathlessness, because the brain drives those breaths from the brain stem, so a very primitive function. And there are nerves that come down from the brain stem to the muscles of breathing, like the diaphragm and the muscles of the rib cage, and that leads to the breathing pattern in and out. So that's fine, but there are also fibers that go back up the other way that send signals back up from the lungs to the brain that measure how much stretch is actually happening, how much are the lungs actually expanding in response to each of these breaths. And if the lungs are not expanding as much as they should because they are stiff with pulmonary fibrosis, then the brain is going to get confused about that. And these signals are going to be sent up to the higher cortical centers in the brain where we process that information. And that's going to lead to a sensation of shortness of breath, because there is uncoupling from what the brain thinks should be happening in terms of the signals it's sending down to the respiratory muscles, and what is actually happening as determined or as sensed by these stretch fibers in the lungs, an uncoupling. And that's interpreted for the higher centers as shortness of breath. So most people who are short of breath with pulmonary fibrosis, it's not because of lack of oxygen or hypoxia, it's because of this neuromechanical uncoupling, which is why efforts to try and retrain the brain to alter how it perceives these signals are actually the mainstay of breathlessness management, certainly in early pulmonary fibrosis, and pulmonary rehabilitation programs, and things like the use of a handheld fan blowing cool air on the face, held 6 inches from the nose and mouth, blowing cool air over the nose and mouth area, itself sends signals up to the brain that interfere with the perception of breathlessness in a beneficial way. And that's an evidence-based treatment. I'm not going to talk any more about the management of breathlessness at the moment, but really just to try and link that in to some of the abnormalities that we see in pulmonary fibrosis lungs in terms of the stiffness and lack of stretchiness of those lungs. So we've really come to the end of my talk here. We've gone through some clinical features, some ways that we investigate the lungs, risk factors for pulmonary fibrosis, tried to link those into what goes on in the fibrotic lung at a cellular level, some thoughts about the actual molecular problems in terms of senescence, premature aging that may be driving that, and then some of the consequences of those stiff lungs in terms of lung function and symptoms. So at this point, I'm going to finish and hand back over to Steve to moderate any questions and answers. Steve.
Great. Thank you very much indeed, Simon. That was absolutely excellent as usual. So clear, difficult concepts put across in a way that I hope everybody on the webinar will understand. One person said, a friend of mine from Germany said, this presentation is absolutely excellent. Thank you for your very informative insights. So it's great, really, really good. Some interesting questions as well coming up. First interesting one, is there a connection between pulmonary fibrosis and other autoimmune conditions like Crohn's disease? Is the first question. And linked to that one, there is pulmonary fibrosis in sarcoidosis, also genetic. So this is around genetics, I suppose.
So good questions. The autoimmune conditions linked to pulmonary fibrosis tend to be those rheumatic diseases, rheumatoid, scleroderma, autoimmune myositis, mixed connective tissue disease. Crohn's disease is an inflammatory disease of the gut that is not particularly linked to pulmonary fibrosis. Actually, sometimes you get lung problems in Crohn's disease, but more related to those airways that take the air down to the business part of the lung. So not so much of a pulmonary fibrosis issue. But Crohn's disease is a fascinating autoimmune disease of unknown cause. And related to the link to sarcoidosis, actually under the microscope, Crohn's disease is quite similar to sarcoidosis in terms of these classic granulomas that occur. Is pulmonary fibrosis in sarcoidosis also genetic? Well, fortunately, most people with sarcoidosis don't get progressive pulmonary fibrosis. Sometimes they may end up with some scarring as related to the sarcoidosis, but fortunately, if you treat the sarcoidosis, that fibrosis, in my experience, rarely progresses. Now, okay, there
less
are
than 5%, yeah?
Yeah, there are a few exceptions. And in fact, Steve, if I saw a patient with sarcoidosis who appeared to have progressive pulmonary fibrosis, I would be a little bit suspicious that they'd actually developed completely independently a separate type of pulmonary fibrosis, like IPF, for example. And, you know, especially if they had some of the IPF risk factors that we talked about there. So it is possible to be unlucky and have two different conditions. So luckily, fibrosis in sarcoidosis is not usually progressive. Yes, there's a genetic component to sarcoidosis as well, and also a big environmental component, but the genes and environmental components are different in sarcoidosis compared with pulmonary fibrosis.
Thanks. I mean, following your logic just then, rheumatoid arthritis ILD, in other words, pulmonary fibrosis associated with rheumatoid arthritis. Are we sure that they're one condition, or could they be a case of rheumatoid arthritis and a case of pulmonary fibrosis caused differently?
Yeah, and that's a very good question. So if a patient with rheumatoid has pulmonary fibrosis, how do we know it's definitely rheumatoid pulmonary fibrosis? They haven't separately developed IPF, for example. Well, that's a very good question, and that crops up not infrequently in the clinic. The risk factors for getting pulmonary fibrosis, if you have rheumatoid, overlap with some of the risk factors for other types of pulmonary fibrosis. So increasing age, male sex, and having smoked tobacco in the past. But it tends to occur in people with long-standing rheumatoid, Steve. So I think your question is particularly pertinent in a patient who has newly diagnosed rheumatoid. And you can't really have rheumatoid without getting diagnosed, because if your joints are stiff and swollen, you know about that. So someone with newly diagnosed rheumatoid who's also got pulmonary fibrosis, I would be suspicious that actually the pulmonary fibrosis may have been there for a while and may represent IPF, for example.
I mean, I met a number of RA-ILD patients who have been diagnosed as NSIP, IPF, various things, and only later they show a bit of rheumatoid factor in the blood, and they get called rheumatoid arthritis ILD.
Yeah, we know in these other conditions like IPF, if you just look at the autoimmune blood tests, they may pop up positive sometimes.
Yeah. Okay.
What does that tell us? That tells us that, well, there may be a bit of an autoimmune component in classic IPF, for example. I mean, in the past, it's mattered, hasn't it? Because in the past, you could only get offered an antifibrotic drug if you had IPF.
In
and
the
if
UK.
it was labeled as rheumatoid pulmonary fibrosis, you could not get the drug. Now that we're doing more lumping together rather than splitting apart, if you have rheumatoid and pulmonary fibrosis and it's progressive, then you can at least get offered one of the drugs. So things are improving in that respect, which means that little kind of technicality of what you call it probably matters a little bit less. But I completely agree with you that if a person's not had long-standing rheumatoid and they've got pulmonary fibrosis, then it may be two different conditions.
Great, thanks. A quick one now. Can long-term methotrexate cause pulmonary fibrosis?
Yeah, this is a question that crops up on a regular basis at scientific conferences as well. So the textbooks say that methotrexate, a commonly used immunosuppressant drug used to treat rheumatoid, can cause pulmonary fibrosis. All of the evidence says that that is not true, that it's the rheumatoid that's linked with the pulmonary fibrosis, not the methotrexate. And one of the bits of evidence for that is that methotrexate is also used to treat psoriasis, a skin condition, and ulcerative colitis, an inflammatory bowel disease, a bit like Crohn's disease. Neither of those two conditions are linked with pulmonary fibrosis, and methotrexate treatment in those two conditions is not linked to pulmonary fibrosis. So in other words, it's not the methotrexate, it's the rheumatoid. Now, methotrexate can occasionally cause a kind of short and sudden damage to the lung called a pneumonitis. So we don't like to use methotrexate in people who've got bad lung disease, but usually it's not the methotrexate that's causing pulmonary fibrosis.
Great, thank you. An interesting question here, which comes up very often. Can you clarify why FVC, forced vital capacity, the volume of air in the lung, is used as the main determinant of lung function? not DLCO, which is the gas exchange, I understand.
Yeah.
I have a friend, for example, at the moment who is on a 79% FVC, 25% DLCO. He'd only just been able to be given the drugs in
Yeah. Yeah, so the DLCO is a measurement of what's called gas transfer. It's done on a breath hold test, part of the lung function test. A couple of reasons. One is that FVC seems to be more reproducible. That is, if you do it on 2 different occasions, you're more likely to get a similar result rather than the DLCO, which is prone to a little bit more test-to-test variation. The other thing is that the DLCO is more prone to be affected by other conditions, such as emphysema, if the patient has some smoking-induced emphysema, as well as pulmonary fibrosis, which will tend to drop the DLCO, or what's called pulmonary hypertension, which is an increased pressure in the blood vessels supplying the lungs, which may occur in lung disease of any type. And if that starts to happen, that tends to drop the DLCO as well. So it's more reproducible and less prone to interference by other conditions. Having said that, neither of them are great as a main determinant of lung function. It's just that the FVC is better. So it would be nice to have an even better measurement.
That's very helpful, because the friend I think about does have pulmonary hypertension as well, arterial hypertension, which explains it. Interesting one here. My husband and I both have chronic fibrotic hypersensitivity pneumonitis. We're told it's very rare. Please comment.
Yeah, it probably is quite rare. If there's an identified allergen, such as birds or mold or something, and you can remove yourself from it, then you probably do better. But those who get pulmonary fibrosis, so the fibrotic type, probably got other risk factors, including the genetics that predispose to pulmonary fibrosis. So the only explanation could be that both you and your husband have both inhaled or have been exposed to some sort of allergen that's triggered this. Now, if you can identify the allergen and therefore remove yourself, that's great. The trouble is that many cases of chronic fibrotic hypersensitivity pneumonitis, we can't identify what it is that's being breathed in, and therefore it's impossible to remove oneself from that exposure. Other than that, that's the only explanation other than bad luck.
Great, thank you, Simon. Biopsies, a big topic. I mean, many of us have had biopsies in the past. A question here. A friend, no, it seems all my friends are on here tonight. Somebody I know has said that he received a diagnosis for BOOP, COOP, NSIP, and ultimately UIP, and says wonders whether VATS is used commonly still, or has it been superseded by high-resolution CT scans so that it's not really necessary.
Yeah, so a number of these unfortunate 3- and 4-letter abbreviations, some of which were proposed by this guy Avril Liebau in the 1960s, like UIP, for example. But there are other unfortunate abbreviations, some of which you mentioned there. They may all coexist in the same biopsy or in different biopsies from different parts of the lungs, illustrating that these diseases are a bit patchy and a little bit variable. So you have to put it together with other information and how the disease is behaving, for example. Is it behaving like progressive pulmonary fibrosis? But you wouldn't be alone to have these multiple different diagnoses. I think it's more useful now, as we've discussed, to lump a number of these things together, in that if there is evidence of fibrosis in the biopsy and there's evidence that the disease is getting worse, then that's progressive pulmonary fibrosis. But we still do surgical lung biopsies, that's VATS, video-assisted thoracoscopic surgical biopsies, but not so many as in the past. The CT technology is really designed to guess what the pathology on the biopsy would show. So I'm not convinced that CT technology is improved to a level where we don't need biopsy at all. But we should also be cautious about getting a biopsy because there are some risks to it as well. And now that we know that if there is progressive pulmonary fibrosis, that there are treatments that we can offer, that may lead us to do fewer biopsies in the future to avoid getting into this confusing terminology issue, which kind of detracts from the real issue about, is it progressive or is it not progressive? And that's really the key question.
Yeah. And linked to that, I mean, another colleague from Ireland asks, are there guidelines for the repeated use of CT scans? Because I understand in the UK, we use them less frequently than, for example, in the States, where they're used as regular monitoring of the disease. Or would that be unfair as a statement?
I think practice probably varies, but there is not that much utility. In my own practice, I don't routinely repeat a CT scan after the initial diagnostic scan, unless I think something unusual has happened, some other condition has occurred, or the clinical picture is confusing as to what is actually going on. So most of the time, it's probably not necessary to do another CT scan because we can monitor the condition with lung function. A chest X-ray gives us a rough idea what's going on, and occasionally you might need another CT if you think that you really can't explain what's happening. Yes, in other centres they may routinely do a CT scan, but I don't think there's any evidence that that adds to any useful information to a patient's care.
Great, thank you, Simon. So final question, COVID and the link between COVID and progressive pulmonary fibrosis. Where do we stand on that now?
I didn't think we'd get away without a COVID question this evening, Steve. There was a lot of concern, wasn't there, at the outset of the pandemic 2 years ago, that severe COVID pneumonia, something, of course, that we saw a lot of pre-vaccination when people got really sick with COVID, that bad COVID pneumonia was going to lead to scarring of the lungs, which might turn into progressive pulmonary fibrosis. Luckily, we've really not seen that at all, even in the people who had severe lung injury with bad COVID and were on a ventilator in ICU. Yes, they may get left with a bit of scarring, but it does not seem to be progressive. And I think those few patients who seem to have progressive pulmonary fibrosis after COVID almost certainly had a bit of pulmonary fibrosis beforehand that wasn't really recognized. And that's what has been picked up afterwards. So fortunately, it doesn't seem to have been a major clinical problem.
Well, Simon, thank you very much indeed. Yeah, that's been a really excellent way of spending an hour on a nice summer's evening in the UK, at least. But really, really very informative. You can tell by the questions that you've generated here. It's been great. So thank you very much for your support. Thank you for your support to patient organisations in the UK as well. And we hope we'll see you again, maybe at the summit. And everybody, for your diaries, don't forget to put it in now that the second European Pulmonary Fibrosis Patient Summit will be held from the 3rd to the 5th of November, a virtual event that's going to have lots of exciting and interesting presentations and discussions in it. I'd just like to thank, in closing, the team of the European Pulmonary Fibrosis Federation Secretariat, Alba and her colleagues, for brilliant support in getting the whole process up and going today. But in closing, we've had 100 people with us tonight. Thank you all very much for sparing your time. Then we'll look out in 5 weeks' time. We're going to have the second in this series, which is going to be on the genetics of pulmonary fibrosis. So look forward to that. Thanks again, Simon, and bye-bye, everyone. Have a nice evening.